I am privileged to be a founding member of the Santa Fe Group. It was really the brainchild, I think, of Larry Meskin. If you really try to dissect where it came from, it was a conversation between Larry Meskin and Dom DePaulo. And I might have entered third or fourth, I'm not really sure. Art Degoni from the University of the Pacific was involved very early on. I like to think I was the third person into the Santa Fe Group. And it wasn't the Santa Fe Group at that time, of course. It was just a group of people who were interested in trying to make a difference in healthcare in general and oral health care in particular. The concept was one in which people would be invited to join the Santa Fe Group on the basis that they had passion for the issues of the day and were willing at times to perhaps risk their career by virtue of saying things that were not necessarily commonly accepted. So these were people who were well established in their various positions, who were willing to take risk for the greater good. And it was a great group of people, and still is, while it's been expanded through the years, to be associated with for that reason. Larry Meskin was sort of the typical person that lights up a room, but not so much with his own persona. It was his way of pulling out your persona. And so, much like some of the other members on the Santa Fe Group, whenever you were working with Larry, it was never about Larry or Larry's career. It was about you and your career and the important things that were going on in it. And so he had that way with his students, he had that way with his colleagues, he had that way as editor of the Journal of the American Dental Association, always pulling the best out of people and willing to suppress his own interest to a certain extent in his own career for the greater good. Speaking of his role at the Journal of the American Dental Association, he had a stellar, I'm going to use the word reign, because he always managed to pick topics that required a great deal of insight and a great degree of political skill to address. So he would talk about things that were on the edge of what were generally considered acceptable for dentists who practice in the United States, and always inspired them to think a little bit. He knew not to go too far, which is why he had such a long run as editor of JADA, and I think we're all well served because of that run. So as I think about the delivery of healthcare, the easy thing to say, and it's almost trite, is to say the system's broken. I think the educational components of the system are broken, and of course it plays out as healthcare is delivered based upon the start that we see in educational settings. And as I try to understand it, and I don't pretend to fully understand all aspects of it, I look for clues that would help me, perhaps in my own institution, address some of the problems. And one of the things I've seen for some time is this healthcare pecking order, where traditionally the physician is at the top of the heap, then there will be a dentist, then there will be a nurse practitioner, then there'll be a nurse, then there'll be a dental hygienist, dental assistant, and so on down the line. And that so galvanizes the individual professions as to sort of paralyze our ability to focus on the patients first, and we miss the opportunity to engage in collaborative care. And we see so many times how we can benefit by interacting with people who understand bed sores and how to manage them on a day-to-day basis, as opposed to writing a script for the management thereof. And so nurses and physicians interacting in a more respectful way than they had traditionally interacted, I think is going to be important to delivering better care. Dentists willing to interact with physicians and nurses and pharmacists in ways that I think reflect the training that dentists have. Paul Goldhaber used to like to say, dentists are the most overeducated profession for what they do and the most undereducated profession for what they should be doing. And so let's take some of this presumed excessive education that really prepares us to interact with other health professionals in responsible ways, mitigate, drop, mollify, whatever the right word is, this is pecking order, and just get together and work with people of all types of training to deliver better care, both to the elderly and across the board in this country. I think certainly that managing care in the elderly would be an important catalyst to get the professions working together. Why? Because the elderly, with their multiple diseases and their polypharmacy, are among the most difficult of management cases any of us would see in an individual health profession. And so the real need to assist the patient should be forcing us to collaborate better than we typically do on a patient that's relatively healthy that might have an isolated problem. It's been around a long time. We know that at least in dentistry, Dr. Meskin was the first to establish a program, and I'm just thrilled that it continues to this day. And he's done very well, and he's seeded scores of people around the country to sort of follow his lead in educating health professionals, in particular dentists. And yet we see it's not enough, and it may never be enough if we don't figure out how to benefit from what's taught in other professions. So I think at this particular conference we heard about Apple Tree Dental Care. I had only a vague familiarity with that group until I attended this conference. I was very impressed with what I learned about them in some detail today. This concept of acknowledging that certain groups, at least at the current level of reimbursement in the United States, could sort of take one group that's well reimbursed, children, and apply it, the resources therefrom, to the elderly in creative ways so that the entire population benefits was fascinating. The fact that that is best accomplished with people who are on salaried positions was an important revelation for me. Not unexpected, but I might not have come up with that on my own. So I think to take that concept and to see if there isn't some way to apply it across a more broad-based health delivery paradigm in a private practice model would be of interest. I'm not sure exactly how to do that. Does it mean that independent practitioners would hire salaried people who would try to apply the Apple Tree principles? Could work. That could be worthy of a demonstration project. Certainly if it works in that model, it becomes more widely available. I was curious to hear that there are other operations that sort of sprung from the Apple Tree Group that exist in other states, and they seem to be able to sustain the model. So there are people out there who care. There are people who will work for a fixed salary. There are people who understand the need to take assets where a slight profit can be made and apply them to an underserved population in very creative ways. So I think that's something that could be expanded. Certainly the most exciting thing I heard in terms of what might be tested on a more widespread basis. So dentists are well trained in pharmacology, maybe not as well trained as they should be, and this is where we need to constantly be thinking about the dental curriculum as more and more drugs are brought to the marketplace. And so we need to follow that, but then other barriers arise. So for example, when I was in the corporate world, we were very much involved in smoking cessation to be delivered as an aid to patients who suffered from periodontal disease in the dental office. When I went to dental school, there was a slight perceived association between smoking and oral health, in particular periodontal disease. But of course, it's now widely known that smoking is almost as important as plaque in terms of an etiological vector to contribute to excessive progress of periodontal disease. So it is right within the purview of the dental practitioner to be able to apply drugs to help modulate that component of one of the key diseases of the oral cavity. And yet, when the company I used to work for launched a product for smoking cessation, dentists objected, as it was not within the purview of the dental profession, or they believed it was not within the purview of the dental profession. Dental societies objected, and some state boards of dentistry objected. At one point, even the FDA started asking questions about whether it was in the purview of dental practice and whether dentists had the skill set to be writing for this particular prescription. And the odd part of this all is that not 2 years later, these products went over the counter. So, as I like to say, Joe Sixpack could walk in and buy a patch, to put on, his arm to help with the smoking cessation problem. And yet, these highly skilled professionals called dentists were not perceived to be adequately trained or interested to deliver the care. We have much work to do if we're to really tap the full potential of the profession in the future. And it will be interesting for me personally to watch what happens as various forms of the dental therapist model begin to make their way into the lower 48 states in the United States. You can certainly look in the short term for the potential enhanced access to care that such a well-executed model and a well-regulated model might create. But in the longer term, if there's to be what I was trained to be as a dentist, if there's to be such a professional, commonly used to be called stomatologist, then clearly we're going to need to be able to rise above the way we currently practice now. We would not drop our technical skills. We would still do some of the more advanced technical aspects of dentistry in the oral cavity, but we would start using this at least as much as this. And if we can achieve that,
then you'd get this.
and if you could achieve that, we would have I think, a better outcome for the American public, and I think the profession will have its dignity sustained.